Hello, greetings from Glasgow. I'd like to thank the organisers for accepting this presentation as a talk. First off, a brief refresher on the lower limb veins, which can be divided into superficial, deep, and perforating. You'll be glad to know we're not talking about the perforating veins, because there's an awful lot of them to remember. Instead, we're concentrating on the deep veins of the thighs, particularly the femoral vein, the deep femoral vein, and the popliteal vein. The nomenclature of the lower limb veins was changed in the early 2000s. Hewitt et al., in their letter to the Journal of Vascular Surgery, reported that 76% of primary care physicians were not aware that what was then termed the superficial femoral vein was in fact a deep venous structure. And this was leading to misinterpretation of the results when a thrombosis of this vein was reported and the referring clinicians did not realize that this was a deep venous thrombosis and did not treat accordingly. The terminology was changed in 2002 with a consensus statement. The femoral vein originates from the popliteal vein at the upper margin of the popliteal fossa at the adductor canal and courses in the femoral canal up to the groin, where it's joined by the deep femoral vein to form the common femoral vein. The impetus for this study came about as I was seeing an awful lot of variations in the anatomy of the deep veins of the thigh, which I didn't properly understand. I went to the literature and found this paper by a French group of anatomists who had investigated variants of the femoral vein. They described the standard modal anatomy as we're taught in medical school. But what they did was took 118 cadavers with 336 limbs, washed out the whole venous system, injected it with latex, and then performed anatomical dissections and painting of the veins. They determined modal anatomy in 88% and variants of the anatomy in 12% of cases. They found unitruncular anatomies to be less common than bitruncular. For this study, we reviewed the images of consecutive patients undergoing our previously described standard contrast-enhanced MRA protocol for arterial disease, including extended phase high-resolution images. This retrospective review covered a 7-month period, and we evaluated the high-resolution thigh scans for variations in anatomy of the femoropopliteal deep venous segments. 2 experienced vascular radiologists independently reviewed the images with subsequent consensus where variance was identified. The deep thigh veins were categorized as per the classification, and an adjunctive audit of all leg vein ultrasound reports over a 2-year period was also performed to assess the ultrasound detected incidence of deep vein variants. This is our comprehensive lower limb MRA protocol, in which we achieve a blood pool effect with conventional extracellular space gadolinium-based contrast agents. We first run a below-knee dynamic image series for the calf arteries, and then a standard 3-station stepping table bolus chase MRA of the aortoiliac, femoropopliteal, and calf runoff. We then immediately perform high-resolution extended phase imaging in the calves and the thighs, with 0.5 mm isotropic voxels in the calves and 0.7 mm in the thighs. These are standard 3D flash examinations. This is all performed with a standard 15 ml dose of gadolinium-based contrast agent. Why do we do this? Well, firstly, for surgical planning. Here's a patient who's already lost a leg and now has critical limb ischemia on the left side, and they don't want to lose the left leg. With the high-resolution venous imaging, then we can clearly show a good great saphenous vein in the calf and in the thigh that is suitable as a bypass conduit. We also quite often discover DVT in patients with critical lower limb ischemia, between 5 and 10% of patients, and finding deep venous thrombosis changes management. We reviewed 322 consecutive patients. In 4 patients, the extended phase scans were missing. 1 patient had had an above-knee amputation, and in 2 patients the images were so poor as to not be assessable, leaving 631 limbs to be assessed. We found modal anatomy in 68% of the limbs. There were some areas of variance. These mainly revolved around small caliber veins, and less than 4 mm is not considered as a duplication. The other area of difficulty was determining the level of the adductor hiatus in order to differentiate deep femoral from axiofemoral venous trunks. As you can see, this is critical for the nomenclature. However, in reality, finding this is quite difficult. Here's a patient with bilateral anatomical variations, but one insert's lower than the other, and it can be tricky to determine exactly where the adductor canal is in order to name the variation. Variant bitruncular anatomies were found in 25% of patients, really quite common. Unitruncular variant configurations were less common in 7% of limbs. Comparing with the anatomical cadaver study, these variants were found in similar proportions in that the bitruncular to unitruncular ratio was 3:1, but we had a rather higher incidence than the cadaver study. Here's a patient with duplicated femoral veins. On the right side, the vein is what we would term flexiform, in that the vein divides and then comes back together again and then divides again. Whereas on the left side, the duplicated femoral vein is duplicated throughout its course in the femoral canal. Here's another example in a patient with, on the right side, bitruncular configuration with an axiofemoral vein, and on the left, a partially duplicated femoral vein. As you can see, we get exquisite anatomy of all the musculoskeletal parts as well, which can sometimes lead us to make other non-vascular diagnoses. This overview slab MIP nicely shows the axiofemoral trunk on the right side. As regards our ultrasound audit, over the 2 calendar years, there were 130 bilateral examinations and 13,432 unilateral examinations, resulting in 13,692 legs. But only 75 reports indicated a duplicated or partially duplicated femoral vein, which is less than 1%, and none of them mentioned either deep femoral or axiofemoral trunks. This suggests that ultrasound is insensitive to deep vein variants. So variants of the femoropopliteal venous anatomy are common and well assessed by MRI in similar proportions but at a higher incidence of unitruncular and bitruncular variants as compared with the cadaver study. These variants are clearly underreported or unrecognized on ultrasound. Venous evaluation is easily added to standard lower limb arterial MRA studies, and the finding of duplicated femoropopliteal segments can potentially have important clinical consequences, such as to allow their use in reconstruction surgery. Thank you for your attention.